Thank you very much. It's been quite inspiring listening to the speakers this morning. Listen to the last speaker all about partnership and the benefits that can bring for patients. And really, I think John and I are just going to try and talk a bit about our own experience briefly and hope that will resonate. I guess you could say, why would you start on a journey of an academic health science network? Well, I think everyone that works in healthcare or in academia, nearly everyone anyway, comes to work to do a good job. I think we're all signed up to believing that and wants to make as much difference as possible and get frustrated in a system that's often very siloed and very organizational. And so if you want to see change happen at a real pace or a real scale, you can get a bit frustrated. I've been very frustrated in the past with the blocks, trying to work through how you might go faster and better. And I think it's impossible not to align against a vision that says, well, we just want to create patient gain, population health improvement. Could you put up your hand if you don't want to do that? You won't get lots of chief executives putting up their hands saying, I don't want to do that. So our approach has been one of relentlessly building relationship capital to try and get that done, building partnerships with very clear goals that people will align to do delivery. And I'll show you a couple of examples. This is our own journey over the last 4 years. We started in the wrong place, okay? So put our hands up. We started with 1 university, 4 teaching hospitals. That probably wasn't the place to start if you wanted to do population health gain. In fact, it'd probably be exactly where you wouldn't start. But anyway, it's where we started. And we've progressively built up a partnership that's now quite big, includes 6 million people, would employ 100,000 staff across the partners. And how have we built that up is through trying to focus on some tangible things that people wanted to do, and we try and help them deliver them. So just give you 2 very quick examples. When we were early on about acute hospitals, not the right place to be, people wanted to say, could we manage to reduce hospital mortality? Could we reduce the number of people dying on wards if we work together? So we set up a community of practice across the partnership to try and do this. And we brought in skills from whoever wanted to play in that space. In fact, the Children's Hospital probably brought the most skills to these adult wards that we had. And we did it as a collaboration. The entity UCL Partners provided infrastructure support. We didn't tell people how to do it. We monitor what happens now on every ward every month and relentlessly reduce the number of cardiac arrests on general wards. People set themselves a target of let's reduce it by 50% in the next 12 months. Tremendously ambitious. The government never set you a target like that. The original partners, 5 of the 6, have already achieved that reduction. And because of that, other people have wanted to join. Now every hospital in the partnership participates and feels very proud to work together on this. It's not a competition. It's how could we help each other. The second example now moves right to 2013. How would you do the same across a whole patient pathway? So everyone knows in this country we have relatively poor survival from cancer compared to Europe. And perhaps we don't really quite want to tackle it head on. If you ask yourself, why is there that poor survival, it's mostly about late diagnosis. So in the bit of London that's UCL Partners, northeast, north central London, 3 million people, there are 12,000 new patients with cancer every year. About 9,000 of those patients will have a good pathway to diagnosis. Will go from a GP to an oncologist or to a hospital. And I caricature it, but about 7 out of 10 of those could expect to be alive at 5 years. 3,000 patients present to A&E. Most of those are going to be dead in 1 year. So rather than focus on a lot of high-end issues, we said, why don't we together tackle that completely? And we'll look at every patient that presents to the A&E departments across the whole partnership and do a root cause analysis. Why did it happen? Does the patient not want to go to see the GP with a lump because they were frightened? Did the GP perhaps not send them or recognize the diagnosis, did not think cancer? Did they go to the A&E department and not get the diagnosis but certainly met the 4-hour target? Or did they go into the wrong part of the hospital and not get through the system? All of the above are true. We're auditing all these patients, but we're doing it in a collaborative way along that whole pathway. At the moment, I could say that if you did present to A&E, 8 out of 10 went straight to palliative care. So of those 3,000, 2,500 are going straight onto a palliative care pathway. If you want to change the outcome, that's the sort of pathway that you would look at, and you'll generate a huge amount of energy across the system to do it. I would more call this an organized social movement rather than something that's top-down. But it certainly galvanizes people. They can track it. They can see how we're improving. We're going to just continue doing that audit relentlessly as a teaching exercise, as a how can we all do better. The vignettes I could tell you from that audit would resonate across here. You know, the people that have used A&E as primary care instead of ever seeing a GP and gone 5 times with a symptom before it's diagnosed as cancer, because that wasn't the A&E's focus. We will make headway with this and then show the results, as we did with the reduced mortality in hospital. So we've progressively grown by building this relationship capital through people who wanted to join. Nobody has to join. We've now actually got 14 HEIs who are part of UCL Partners in some way, if you include the research networks, cover a population of 6 million that doesn't quite fit county boundaries. It fits where you think you travel. So people that live in Stevenage travel to Cambridge, people that live in Watford travel into London, so they've sort of split in that way. 19 clinical commissioning groups. So a lot of relationship building. A very relentless process, and the only thing that will bind people together is actually seeing outcomes that matter to patients. They're not going to be bound together by outcomes that matter to institutions, although that's a good side benefit. So my reflection earlier in the year when AHSNs were getting going was essentially that the things on that screen, that we're just going to keep at this relentlessly. I'm going to hand over to John Took now to talk about putting the A in academic health science centres and networks.